Next we have, I don't think Priya needs any introduction.
No.
So she's going to talk to us about IOL choices in ectopia lentis. Priya, whenever you're ready.
Yeah. So, good morning, everybody. Thank you, all of you, for being here. And I would like to thank Dr. Ajoy Paul for inviting me to his instruction course. So, well, I will be talking upon the IOL choices that you can go ahead in cases with ectopia lentis. Actually, and the previous talk has covered quite a bit of it. So, let me go ahead and see what I can show you a bit differently. I can emphasize on different aspects. So we all know that, the basic thing that whenever you have a dislocation of the lens or a subluxation, whenever it's partial, we call it as a subluxation. We all know that. And if it's total, it's a dislocation total. Our management actually depends on what situation is there inside the eye, the clinical scenario. My clinical choices, they come up very clearly whether this is, the first thing that I see is whether it's a progressive or a non-progressive zonulopathy. So the entire management goes on to that. This is the most important diagnostic criteria which I use for performing the surgical procedure in a case of ectopia lentis. You might have various degrees of subluxations. You might have a minimal one, you might have a moderate one, you might have a severe one. But if it's a progressive zonulopathy, I do understand the aspect that it's very important to keep the bag as much as possible, but when it's a progressive zonulopathy, suppose even if you repair one segment, the other segment is going to go off within few years, maybe 1 year, 2 years, 3 years, or depending on how fast or progressive the zonulopathy is for that particular case. Because we have seen many cases, coming up with implantation of endocapsular ring segments, etc., and everything getting dislocated over a period of time. It's just a matter of time when you have a complication out there for your patient. So this is a very important aspect that comes up. Now, if you have this kind of the choice of intraocular lenses, actually, then again, it depends how you are handling your case, whether you are using a one-piece or a three-piece foldable intraocular lens, and there are various segments which have already been discussed, so I don't go into this. A subluxated lens, okay. So this is a case that you're seeing, it's a mild subluxation. So what you see in this case is that, it's a cataract, mild subluxation going on. There's a history of trauma in this case. So there's nothing much to think into this case, except that when you have taken up this case, you need to assess, how much is the dangling movement coming up from the lens in itself. Because the moment you inject viscoelastic and the moment you do a capsular excis, things quite, they become quite clear. You will assess the movement of the lens which is there at that point of time. And then, the second important thing here is putting up a capsular tension ring. Many surgeons want to put it up right in the beginning because they want to support whatever system is there into place as it is. Some of the surgeons, they like to go in the intermediate stage, when you have created some space in the capsular bag, then you want to put it. And some surgeons, they go at the last, that okay, when we are done with the entire removal and if it's not moving much, the lens is quite stable, then let us do it at the end, because then you do not have any trapping of the cortical matters coming up with the capsular tension ring. So this is all surgeon dependent. You can use, you can put the ring whenever you need it in cases of mild subluxations. They do very well. Again, coming up to the intraocular lens, again, it's a surgeon's choice. There are many surgeons who want to go ahead with a one-piece. Many surgeons go ahead with a three-piece. Totally your choice, whatever you want to put into the capsular bag, because everything is going to remain stable out here. It's a minimal kind of thing. The only thing is that, many times many times I consider putting up a three-piece intraocular lens, not because that, it is specifically indicated, but just because that if there is some another complication coming up in the postoperative period, you don't have to open up the eye. This same intraocular lens can be intrasclerally fixated, and you can go up with the case and it can be settled down at that point of time. Now, actually in this case, there is also the iris has gone off. So the procedure of choice that was described by me and Dr. Agarwal was the single pass 4-through pupilloplasty procedure. And this is our surgical procedure of choice when we go ahead with doing a pupilloplasty procedure. Simple, fast, easy, and it works superbly. It does not have a knot. It has a self-sealing kind of knot which just lies very close to the surface of the iris, and it works really well. So this is how you settle down with this. Coming up to something which is much more bigger, larger. It's a progressive zonulopathy. Yeah, now there are various options again onto this. I would, surgeons would like to do a REX is, putting up ring segments and then doing it. Looks great. results are also great. I don't deny it. But when such kind of cases, when they come to me, I tend to go in with lensectomy because taking into consideration, suppose for the patient, for the lifelong, I think I try to go ahead with the intrascleral fixation for these kind of cases. So now this is a case, so what actually we do in these kind of cases, we go ahead with intrascleral fixation, so 2 partial thickness scleral flaps are being made. Now, you can go ahead with any technique of your choice. Do what is good in your hands. Recently, Yamane technique has picked up very well, and many of the surgeons have shifted over to Yamane technique. They are doing it because they don't want to use glue and other things. They don't want to do peritomy. It's a closed chamber kind of thing. Works very well. You can do it what works well with you. I have done glue IOLs maybe for last so many years, so I tend to do this because I tend to get minimal complications with this surgery. The tilt is less, etc. So I try to go ahead with this surgical procedure. Clear-cut lensectomy is done for this case. The only thing is that, you should know how to go ahead with these kind of cases. You need to make a sclerotomy site. It was shown before by Dr. Ghosh. He also showed you make a sclerotomy site beneath the scleral flaps. The most important thing is you need to have a fluid infusion inside the eye. You cannot do the procedure in viscoelastic. At no point of time your eye or the globe should collapse. So fluid infusion is a must. It should go on. You can use an anterior chamber maintainer. You can use a pars plana infusion. Whatever works well with you, you can do it. But you need a fluid infusion going on inside the eye. You clear up the entire lens. It's a soft lens. It comes off very easily with the vitrectomy probe. Vitrectomy probe works best because it keeps on cutting the vitreous and it keeps on sucking away the cortical matter. So at no point of time you are inducing any traction. So the next thing is doing a glued intrascleral fixation. This is a 3-piece foldable intraocular lens which is loaded. You just hold the tip of the haptic, that what is being shown here, and you wait till the entire intraocular lens has unfolded inside the eye. Once the entire intraocular lens is unfolded, then you pull the tip of the leading haptic. So then the leading haptic gets externalized. Now you have to manage with the trailing haptic. So you flex the trailing haptic inside and you move this, and then you can just leave your trailing haptic, the leading haptic. It does not fall back. What you just saw was a handshake technique. It's the transfer of haptics from one hand to another because you need to externalize it from the right side. So now both the haptics are externalized, and then you go ahead, you can, I always suture, I always consider suturing the corneal incision because these are vitrectomized eyes. You don't want any leakage coming up from any point of time, and then you just tuck these haptics and you are sorted. Tucking of the haptics is very important. Let me emphasize, about 2 to 3 millimeters of tuck of the haptic should be there. So because that is where the stability of the intraocular lens comes. Glue gives only a self-sealing kind of effect. It does not hold the intraocular lens. So that's very important, how much amount of haptic you are tucking, and then you just seal it and you are done with that, and you place the fibrin glue and you are done. So I'll just sum up this. If you have a total kind of thing, again you need to go ahead with thorough vitrectomy and intrascleral fixation. I'll just show you this in brief, just a 1 minute. The handshake rebating method, this is the adaptation of the Yamane method, and what you see here is this is what you need for this is a 26 gauge needle and a 3-piece intraocular lens. We do not get many times 30 gauge needle here in our country, so we just modified this a bit suiting to our scenario. So what actually is done is that the initial steps are same like what we do in a Yamane method, 2 millimeter by 2 millimeter, you just mark. Then with a 26 gauge, you take a long needle, you take a 1.5 inch long 26 gauge needle, and then you create the track and you externalize the leading haptic. The only thing differently that is done here is that, when you make a flange of the haptic with a low temp cautery, you just compress it. So that's called riveting. You compress it so that, your haptic does not slip back inside the eye. So that's the only thing. Why it is done? Because, 26 gauge, it creates a much more thicker track as compared to a 30 gauge needle. So if you create a bulb, the bulb of the haptic, it might slip back. So in order to prevent the slippage, you can just rivete it, you can just compress it, because at that time it's hot and it just gets compressed, so it does not slip back. So this is just a small little modification. I'll just show this video if you're interested. This is how the 3-piece intraocular lens goes in, and you can just thread the leading haptic directly into the barrel of this needle. So this goes in, and then you just externalize this haptic. So this is the leading haptic that comes off, and then with the low temp cautery, you'll just create a bulb. You can even, if you actually do not have a low temp cautery, you can even use the ballpoint cautery, which we always had previously. You know, you can just heat up that ball, and with that ball, you can bring it closer to the haptic, and then the flange automatically comes off. One other point I would like to say is that the flange with the PVDF haptic is better than with the PMMA haptic, because the sensor 3-piece and all these are all PMMA haptics. They are not PVDF. PVDF haptics, actually they are not available. CT Lucia lens from Zeiss, I have no financial interest, but it's not available. What you see abroad, all the surgeons, they are using these PVDF haptics. They don't use these intraocular lenses. So the kind of haptic bulge and the flange that you create with these lenses is going to be different than what you can go through a paper which was published by Dr. Oliver Fendel. He has published the different types of flanges that are created with different types of intraocular lens, depending on the material of what the intraocular lens is. So it's available. I think it was published in JCRS. You can go through it. For the benefit of time, I would just like to end up here. But this is how, you know, the things are there. Thank you so much.
Thank you, Dr. Priya. The main problem I have with you is you make this look so easy, and then we try it and we land up in a soup. I have a question for the last technique which you showed, the flange technique. What if we cannot directly, you know, while injecting the lens, guide the leading haptic inside the 26G?
Yeah. This actually what you saw was described by Dr. Brian Kim. If you cannot do that, it's fine. You know, many of the surgeons, they don't actually dilate the pupil much when you are going to do a Yamane kind of thing. You unfold the entire 3-piece intraocular lens onto the surface of the iris.
Okay.
That's the best thing to do. So your entire IOL is inside the eye. For safety purpose, you can keep the trailing haptic a bit outside the cornea, outside the corneal incision. That's what I mean. And then you can go ahead with the leading haptic, and then you can manipulate it. You go from the needle from this side.
The space is not an issue. The space is not an issue.
No.
Okay. Excellent.
From Dr. Sudipta.
The first case that you showed was a bit of subluxation, not much. For a beginner, I'm asking, that before putting a CTR, can a capsular look in that?
Yes, it can. If you find it's dangling too much, yes, you can.
And then you go on with the complete surgery, and when you have
Absolutely. Yes, yes. You can use at any point of time. Wherever you find something is going.
the difference is bulky for it.
Absolutely. It all depends. Yes, it all depends on what is there at that point of time. So you can handle it accordingly to your comfort zone. Yes, definitely. Why not stabilize it? If it's moving too much, it's definitely advisable.
Dr. Narang.
Do you always make those 3 and 9 o'clock EIs that you make?
Yes,
We usually make it for very high myopic eyes, big eyes. We do it because these eyes, they have a wide to wide diameter of about 13 millimeters or more, and our IOLs are not that big. So because of that, the companies are not making 14 millimeter IOLs for us. But this is how we came up, and we have published this also in JCRS. You know, you make these sclerotomy sites a bit anterior. But point is, when you come a bit anterior, you know, there is a tendency that when you make a sclerotomy site, you will drag the iris tissue, because you have come anterior, you are not behind the iris. So that is the main contention. To avoid that, you do a peripheral iridectomy, so that when you are entering inside, you do not drag the iris tissue and you do not cause an iatrogenic iridodialysis. So that is the concept behind it.
Yeah, for the tucking, are you using 26G needle or 27 or any other needle for tucking of the
26. We use 26. But I have seen many people, they use a normal sclerotomy, the MVR blades also, and they are making it. But we use 26.
Enough to hold the lens with?
Enough. It is enough. 26 is enough.
Yeah. Thank you so much for the excellent talk, which is a very good learning point.
We have
Thank
a
you.
question there.
Oh.
How far do you make the sclerotomy port from the limbus?
It is about 1 to 1.5 millimeters. Depending, if the eye is a big myopic and a big eye, we might come at 1 millimeter. So that is where we do a peripheral iridectomy. There are two things we do. We come more anterior, that is about 1 millimeters instead of 1.5, and we do a peripheral iridectomy so that we don't damage the peripheral iris tissue and we don't drag it with a needle.
And my second question is, when you put a CTR ring in the subluxated lens or the capsule, so where the area of subluxation, for example, in your case, it was probably considering the right eye, it was inferior temporal quadrant. So would you prefer putting the ring in that quadrant the first or the last?
The ring is almost like it covers everything, like, so there's just a very small gap that is left out. So that's fine, like.
No, I mean, if there is more subluxation, for example.
Then you have, only a ring will not suffice. You need segments then. Then you have to use endocapsular segments. So then you have to fix them with the sutures. Everybody, I think, I don't know if Gore-Tex, everybody is having it, but they are using the sutures. These days, what has picked up is, the Sergio Canabrava's flanges. He uses a 5-O-proline. If you are using a segment, and through that hole, you just pass your proline, you bring it out, make a flange, and you are done. So you're not struggling with any of the suture inside the eye.